So, good morning, everybody. Welcome to Medical Grand Rounds. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. I'm delighted this morning to continue our Meet the Professor series and introduce Dr. Adriana Lazarescu and congratulate her on becoming a professor in our department. So Dr. Lazarescu is in the Division of Gastroenterology. She got her MD degree at the University of Toronto, followed by internal medicine at Western Ontario and London, Ontario, and GI training in Queen's University in Kingston. She then completed a CIHR-funded fellowship in esophageal motility at the Catholic University of Leuven in Belgium with Dr. Daniel Sifrim. In 2008, she joined the Division of Gastroenterology at the University of Alberta. Dr. Lazarescu's main clinical and research interests are in GI motility and in medical education. She's the director of the GI Motility Lab at the University of Alberta and president of the Canadian Neurogastroenterology and Motility Network. A former director of the GI residency training program, Dr. Lazarescu is currently director of the Neurogastroenterology and Motility Fellowship Program and chair of the GI Competence Committee. She's received numerous education awards, including the Canadian Association of Gastroenterology Educational Excellence Award, Alberta Society of GI Distinguished Education Award, and the CAME Certificate of Merit. So I will hand it over to Dr. Lazarescu.
Thank you, Norman, and good morning, everybody. I'm very excited to be here to go over some of the things that I've been able to do in my career and talk about my passions, as Norman mentioned, motility and specifically the esophagus. And I've done a lot of things in medical education, but what's closest to my heart is what I've been able to do in medical education within the realm of motility. So my objectives for today is to review with you the Chicago 4.0 classification of esophageal motility disorders, which is our most up-to-date classification, and tell you a little bit about new technology that we're using in the field of esophageal motility that helps us with diagnosis and management of these disorders. And finally, illustrate how the use of medical education can help advance clinical practice as well. So I'd like to start with a slide that perhaps looks a little scary, but just to give you an idea of what we're essentially looking at. So you may remember that the top third of the esophagus is skeletal muscle, the bottom 2/3 are smooth muscle. And when you initiate a swallow, the signal to contract goes to the entire esophagus at the same time. If the esophagus actually contracted from top to bottom, that would be counterproductive, as you can imagine, that things would get blocked. So the esophagus is actually quite clever because towards the distal half, you have some nitric oxide neurons that inhibit the contraction for a while so that you can get that gradient so that you start contracting at the top, then gradually towards the middle and towards the bottom. And that's how you get a peristaltic wave. If you were to measure pressures of contraction at different levels in the esophagus, you would see that at the top, there would be a spike where it contracts here, and then a little later, further down, and so on to the very bottom. And this green dotted line is meant to show you what's called the intrinsic latency gradient. So this is the esophagus waiting to squeeze at the bottom after it squeezes higher up. With respect to the lower esophageal sphincter, which is at the very bottom, which connects to the stomach, it is tonically contracted and has to be inhibited in order to relax during swallows. And when we assess esophageal motility, this is what we're looking at. How did this all start? Well, we do a test called an esophageal manometry study, which initially started in the 1960s. And back then, we had these catheters that were called water perfusion catheters. So there were these tiny little openings at various levels that trickled water, and we were measuring the resistance to that trickle, essentially. Initially, there were only 5 pressure sites, so you would see that we would measure at different levels, and there were a lot of breaks in between. These catheters were huge. I mean, they were at one point about the size of your pinky finger, if you can imagine putting that as a nasogastric kind of access. Over time, obviously, they became a little smaller, they became solid state. But the information that we got is essentially tracings. So again, these types of spikes that are one after the other. And I don't want you to think of them as distinct areas of contraction. These are just the points where we're measuring, but essentially it's a stripping wave that goes from the top to the bottom of the esophagus. For those of you who are early in your career, or maybe the residents who are maybe watching, the reason I got interested in the esophagus is because I was an internal medicine resident who was keen on GI, and this was in London, Ontario, and Dr. Rick Reynolds, who was the motility expert there at the time, basically unrolled this huge piece of paper that had all the tracing from top to bottom. And it's pure physiology and pathophysiology. It's absolutely beautiful. And in a sense, what we're doing now, despite all the technology and software that I'm going to show you, is much the same thing. So some of you may remember various names of esophageal motility disorders, such as achalasia, nutcracker esophagus. You may remember diffuse esophageal spasm, or even scleroderma esophagus. A lot of that has changed. This is the initial formulation of a classification of esophageal motility disorders done in 2001 by Dr. Speckler and Castell. And fun fact, Don Castell was the one that the Castell sign for the spleen is actually named after. A lot of this has changed. Some of it has stayed the same, and I'll walk you through a little bit of the history of how things happened. Here we are now. So in about the late 2000s, we got to high resolution esophageal manometry. So we now have catheters that have 36 sensors, and they are as small as your cell phone charging cables. So they're a lot softer, they're much more comfortable, a lot more sophisticated. And with this, we are getting a lot more information. So categorizing what's happening, understanding what the physiology and pathophysiology of the esophagus has reached a lot more sophistication. So as I told you, we're getting the same type of tracings that we got way back in the 60s when this started. But Ray Klaus out of St. Louis came up with an idea. What if we took these tracings that you see over here and we made them 3D? So this is proximal esophagus, this is distal esophagus, towards the right is time, and the peaks, these little hills or mountains, are the amplitudes of the contractions. And then if you make this contiguous, it looks like essentially like a topography map, like you would see for mountains or landscapes. And then you give them colors for different pressures, and this is what you end up with. And then you look up from the top, and you're going to get, this is what a swallow would look like. And ta-da, this is high-resolution esophageal manometry nowadays. So to orient you, at the top, we have the upper esophageal sphincter. At the bottom, we have the lower esophageal sphincter. And this is the peristaltic wave going through. The colors, the red or pinks are higher pressure, the greens and blues are lower pressure. We're not meant to just look at colors. Obviously, the software will measure this for us. But this has revolutionized how we look at the esophagus and its function. It gives us a lot more information than we used to get from the tracings. I want to spend a minute and talk about some metrics that we use to understand how we actually come up with our diagnoses. So the thing to understand is that a swallow takes about 8 to 10 seconds to go through the esophagus from top to bottom. And when a swallow starts with the relaxation of the upper esophageal sphincter, the lower esophageal sphincter will relax as well. Not necessarily 100% right off the bat, but it will be relaxed for that entire time. That's actually also why people reflux during meals, because your LES is relaxed. And this is a very important relaxation. We'll come back to that because if it doesn't happen, there can be problems. The other thing that's important is, as I mentioned in the beginning, that the distal esophagus has to wait to contract later, so not at the same time as the proximal esophagus. So we measure this thing called the distal latency, so the time between the start of a swallow and when the distal esophagus contracts. If it contracts too soon, if there's a very short distal latency, that can be a problem because the contraction could be in front of the food bolus, blocking it, or on top of it, which can actually cause pain as well. Last but not least, the contractions of the peristaltic wave have to be of a certain amplitude to be effective, to actually push food down. So this is what we call the distal contractile integral, again, something that the software would calculate for us. In the old days, we would actually measure pressures, millimeters of mercury, and normal used to be between 30 and 180. So we use these parameters when we interpret esophageal motility studies, and I will show you as we go along. I thought I'd start with something that most people have at least heard of, which is achalasia, which is the quintessential best understood esophageal motility disorder. Patients who have achalasia have progressive dysphagia with solids and liquids. They might have chest pain. They often have bland regurgitation. They'll lose weight. And with time, this can actually be a very detrimental condition. The key features are twofold. One, the lower esophageal sphincter does not relax during a swallow. And two, there is no peristalsis in the esophageal body. And I should specify that that's mainly in the smooth muscle component of the esophagus. On the right side, you're seeing a barium swallow with a typical achalasia esophagus, which is dilated, and the bird's beak at the bottom. I will tell you that not everybody with achalasia looks like this, but this is what I guess the most quintessential textbook kind of photo. They can dilate their esophagus ridiculously because it becomes a storage space as food is not going through the lower esophageal into the sphincter, into the stomach. Why does achalasia happen? We don't know what triggers it, but the underlying pathophysiology is a loss of nitric oxide neurons. So the cholinergic neurons are not balanced out. It's easiest to understand at the lower esophageal sphincter. As I mentioned, it is tonically contracted through acetylcholine. So since you have no nitric oxide to inhibit it to relax, it does not. Interestingly, achalasia was known about even in the 1600s. I read a report of someone using a whalebone to dilate the esophagus. So we've come a long ways from that. So the main treatments for achalasia, there's a couple that have been around for decades, the top two, one being a pneumatic balloon dilation of the lower esophageal sphincter, and the one on the right, which is a Heller myotomy, more recently with the addition of a loose fundoplication. So they've been the mainstay of management of achalasia, and up to really, I would say, the last 10 years, and maybe in some places even still, which one you choose is basically about availability. Do you have a surgeon who does this, or do you know somebody who can do a dilation? What is available? And what's been exciting, as you will see, is that now we can customize treatment based on some features on manometry. I also wanted to mention at the very bottom a newer treatment modality called per-oral endoscopic myotomy, POEM for short. And what it does is actually pretty much what the Heller does, except it's endoscopic. So they make a tiny cut in the esophageal mucosa. They tunnel themselves down so that they go all the way to the G junction, and then they cut the circular muscle in the esophagus, then close the opening tunnel at the top. So in around 2008, just about when I came into practice, Peter Corliss and John Pandolfino at Northwestern University in Chicago published the first high-resolution manometry classification of achalasia specifically. And what they noted was that achalasia is not one single type of presentation. There were three subtypes. The most classic type of achalasia that with that dilated esophagus, bird's beak, and so on, would be a type 1, which you're seeing on the left. So in this case, upper esophageal sphincter at the top, lower esophageal sphincter at the bottom. Even though a swallow has occurred, there is no peristalsis in the esophageal body, and the lower esophageal sphincter does not relax. The second type of achalasia, type 2, is like type 1 in many ways, but there's still a bit of tone in the muscle of the esophagus. It's not as dilated. So you get these streaks, essentially, which is called pressurization. Type 3 achalasia is the oddball. It's the one that's much rarer, and we think that it's similar to what in the old days used to be called vigorous achalasia, if you've ever come across that term. And the problem in type 3 is that not only is the lower esophageal sphincter not functioning, and not only is there an absence of peristalsis, but this angry looking right angle triangle in the distal esophagus, those are spastic lumen obliterating contractions. This is not peristalsis, it's the esophagus clamping down at high pressures. And the issue in type 3 is that the blockage is not just at the G junction, it's higher up because the food bolus can actually be above this contraction. So you can already imagine that the treatment that type 3s might need might be a little bit different than 1s and 2s. And in fact, even in the original paper of the Chicago 1.0 classification, with very small numbers admittedly up here, type 1, type 2, and type 3, the success rate of various treatments such as dilation or myotomy varied between the subtypes. You can see 0 and 0 here for type 3, and we'll come back to why that is in a second. But again, there were hints that really we should not be treating every patient with achalasia the same way. Many studies have been done in achalasia, as you can probably imagine, but one of the few that is actually randomized and prospective was the European achalasia trial, which compared pneumatic balloon dilation and Heller myotomy. And you can see that just globally, regardless of treatment, the success rate for these type 1s, type 2s, and type 3s is different right off the bat. And essentially, if you needed to get, if you had to have achalasia today, type 2 is the one you'd want. Okay. Breaking it down a little bit more. So for type 1 achalasia, the light gray is pneumatic dilation and the black is the Heller myotomy. So in type 1, there wasn't a statistical significance between these two treatments. In type 2, the pneumatic dilation was better. And in type 3, there was obviously a significant difference. The Heller myotomy seemed better. I'm going to put an asterisk next to that because in type 3 achalasia, the amount of spasticity or the length of esophagus involved varies. A Heller myotomy can only cut so much of the esophagus because the surgeon starts below the diaphragm and they're actually going through the diaphragmatic hiatus and cutting upwards. So they can only reach so far. So it's quite successful in patients who don't have a long length of spasticity in type 3. But the best treatment is POEM, as we will get to in a second, because in a per oral endoscopic myotomy, the endoscopist can choose the length of muscle of the esophagus that they cut. So with this type of information, Dan Sadowski and I started the achalasia clinic in 2016. I actually had to go back into my calendar to remember when we started it because it's been so long. And part of the reason behind it, aside from centralizing the care of these patients, is to do it in a more evidence-based way, in a more personalized way. Not again the sort of, well, we have a hammer, let's use it on this nail. So we very much guide ourselves based on the phenotype, the subtype of achalasia that patients have. On the right side, you're seeing basically a summary of our understanding nowadays for each of the subtypes. So again, for type 2 achalasia, the pneumatic balloon dilation, Heller myotomy, and POEM are very similar in efficacy. For type 1s, there is a little bit of a difference between the surgical myotomy and the endoscopic myotomy, but overall, it's very reasonable. The balloon dilation is a little bit less, but still reasonable. In type 3s, realistically, POEM is the best. Now, it's not, again, that we are rigid, thou must have this because of your subtype. It is always a conversation. And certainly there are other factors that we consider. Pneumatic balloon dilation, there are 3 different sizes of balloon that we can use. And some patients need to actually come 3 times to get dilated, which if you live 8 hours away, you can imagine that can be a hassle. Durability. So as far as length of benefit, because with any treatment like achalasia, eventually symptoms will come back and will require retreatment. The one that we have the best data for durability is the Heller myotomy. So if you are a young person who really, you don't want to have millions of treatments through your lifetime, surgery seems like a good option. Last but not least, until literally last month, there was no POEM available in Alberta. We sent all of our patients to Vancouver or Toronto or Kingston, Ontario. So we did the very first 2 POEMs in Edmonton last month, which is super exciting that we now have greater access. So far in our clinic, we've seen almost 200 patients. We have a standardized workup of investigations, both on diagnosis as well as follow-up post-treatment, and it has been a very rewarding to be part of this clinic. So I've talked to you about achalasia so far, but let's talk more globally about other esophageal motility disorders. I've chosen to start in 2015 with the version 3.0 of the classification, Chicago classification, partly because there were a lot of things before that are no longer clinically relevant. But essentially, our understanding is that there are disorders of EG junction outflow obstruction and disorders of peristalsis. And we've talked about achalasia, that's the one that's most straightforward. Thinking back to old terminology, so the jackhammer esophagus or hypercontractile esophagus is what used to be called nutcracker esophagus. DES now stands for distal esophageal spasm rather than diffuse esophageal spasm. And part of the difference is before, the diagnostic criteria was that you needed to have simultaneous contractions. Now they just need to be premature because we understand they could actually be peristaltic, but just really too soon, which can cause symptoms. I'm going to focus primarily on two disorders, one being EGJ outflow obstruction and ineffective esophageal motility. I was part of the committee that worked on Chicago 4.0 and specifically ineffective esophageal motility. So it's very rewarding for me to have gone through that process and actually be able to implement some of these changes in our practice here in Edmonton. So before I do that, again, just wanted to show you some pretty pictures. This is what distal esophageal spasm looks like on the left side. So it looks kind of peristaltic, but the key feature is that the distal latency is very short. So this swallow is happening too soon, which can affect bolus transit. And this is what a jackhammer or hypercontractile esophagus looks like. It's supposed to be a peristaltic wave. You're supposed to have normal lower esophageal sphincter function, but the contraction amplitude of the peristaltic wave is very high. I have to tell you that we've seen patients squeeze 400 millimeters of mercury in their esophagus. Not only that, but they squeeze for 10 or 20 seconds. So if you can think about that, that's above perfusion pressure. Essentially, when you're eating, your esophagus is ischemic. And you can imagine that that can give symptoms. So let's talk about the opposite end of the spectrum, something called ineffective esophageal motility. And this term, IEM, has been around for decades, but it's meant different things through the years. So when the initial diagnostic criteria for esophageal motility disorders came out, the idea was we know what normal peristalsis is. So obviously you can have a peristalsis that's too strong and peristalsis that's too weak. And this is what IEM is meant to be. But it's actually not as simple as that. So here are some examples. So on the left side, you have a completely normal peristaltic swallow. Next to it, you have what's called a fragmented swallow. So there is a break here that's longer than 5 centimeters when nothing happens. And then the peristaltic wave continues. This is a peristaltic wave that kind of goes from top to bottom, but it's quite weak. So it may not be strong enough to push food down. And last but not least, this is a failed or non-conducted swallow. So there's really nothing much happening in the esophagus when you're swallowing. We used to consider them comparable as far as their effect on bolus transit or symptoms, but that's not necessarily always the case. As you might assume, a failed or non-conducted swallow tends to be far more likely to affect bolus transit and symptoms, though not always. The association between what we see on manometry and symptoms is definitely less than perfect. So let's take a minute to talk about bolus transit, because the assumption in general has been that you see something on manometry, you measure these pressures, so clearly this must affect bolus transit. And as I just said, that is not always the case. But how do you know? How do you actually get objective evidence? So in the early 2010s, this new technology called impedance came about. And you may have heard of it in the context of 24-hour pH impedance testing for GERD, but this is something that is, this is a different use for it. Impedance is essentially how much resistance there is to conduction of electricity. So on the left side, here's a zoomed in as a high-resolution esophageal manometry and impedance catheter. And what you're seeing is these pairs of electrodes, and they are passing a tiny current between them. So if you put this in a liquid, liquid conducts electricity, so there's low resistance to that. So if you measure that resistance or impedance, it will drop in liquid. With gas, there's very, very high resistance to conduction of electricity. As you can imagine, electricity doesn't go through air, so the impedance will spike. Here's if you have these pairs of electrodes going down through the esophagus, the impedance will drop as you swallow a liquid. And just like a peristaltic wave does, it's a sequence. So you can actually see it from top to bottom. In high resolution esophageal manometry, they've obviously colored it to make it easier to see. So here the purple is the impedance. So this is a liquid that goes all the way into the stomach, which makes it much easier for us to see the impact of any abnormalities of motility on bolus transit. So here's an example. This is a fragmented and weak swallow. There's a big break in here. And with impedance, you can see that some of the water goes into the stomach and some of the water remains in the esophagus. So clearly this swallow has an impact on bolus transit. So this is something that we use routinely in our GI motility lab. Coming back to the clinical significance of these ineffective swallows, even if you have a swallow like I just showed you on the previous slide that is weak or fragmented, that does cause bolus retention. As I always say to the residents, the esophagus is allowed to mess up. It's not like every swallow is meant to be absolutely perfect. There's lots of cleanup mechanisms and other ways that the esophagus can take care of itself. So we use provocative testing in an esophageal manometry test to bring that out. I should take a step back and tell you that to do an esophageal manometry test, what we do is 10 individual wet swallows. So 5 cc's of water, and you're supposed to take a single swallow, then wait 30 seconds, then another swallow, and so on 10 times. And you might say, no one ever has swallowed this way in real life. Why are we doing this? Because the esophagus has all sorts of built-in physiologic mechanisms that if you take more than one swallow close to another, the two swallows interact with each other. Sometimes they inhibit each other, sometimes it affects lower esophageal sphincter pressure. So in order to get a pure picture of swallowing, that's why they have to be done this way. But coming back to some of these inherent mechanisms, we use something called a multiple rapid swallows. So these are 5 swallows, so 1, 2, 3, 4, 5, in quick succession. And then the patient is supposed to stop swallowing. And there are 3 things that are supposed to happen normally. One is, as you can see, that the peristaltic waves are inhibited until the very end. And that's normal, because if you just basically started to glug, glug, glug something, and you initiated a peristaltic wave with every single one of those swallows, your esophagus would get so confused that nothing would happen. So it wanted to be inhibited until the very end. But at the very end, what's supposed to happen is that you get the mother of all peristaltic waves, a really strong peristalsis to just clean everything out. And last but not least, your lower esophageal sphincter will be relaxed this entire time, and that's completely normal. So we use this last peristaltic wave to look for something called contraction reserve. So imagine that you have a patient where you do an esophageal manometry and their peristalsis is weak, often failed, and you think they might have an effective esophageal motility. If they can mount a beautiful, normal peristalsis on the multiple rapid swallows, that tells us that the esophagus can rise to the occasion, has the potential to contract properly, so that the weak contractions we saw on those oddball every 30 seconds single swallows might not be clinically relevant. On the flip side, this is used because if you don't have it and you have ineffective esophageal motility, which is often, by the way, associated with GERD, it's important to know this because it can, if you have IEM, it has been associated with post-fundoplication dysphagia. So that's one of the implications of having IEM. Actually, I'm going to take a second before I talk about the new criteria and mention scleroderma esophagus, because this is something that's still floating out there a little bit. So Decades ago, it was noticed that patients with scleroderma had absent peristalsis in the esophagus and a weak lower esophageal sphincter. So basically a completely atonic esophagus that did nothing. So this was called scleroderma esophagus. With time, it was noticed that patients with other connective tissue disorders could have this as well. So it got renamed as scleroderma type esophagus. With more time, it was noticed that this can actually happen in patients who have zero connective tissue disorders. And in fact, of all the people who have absent peristalsis or weak LES, a tiny minority have scleroderma or other connective tissue disorders. What used to happen, however, is we would interpret a study and write scleroderma type esophagus. And the first thing that people would do is, let's look at their hands. Oh my goodness, do you have scleroderma that's been missed? So the answer is no, that's not actually the case. And the esophagus is not the first part of the body that's affected in scleroderma. You'd have to have very obvious bad scleroderma to have it in the esophagus. So that term is gone. We no longer use it because it created a lot of confusion. I know a lot of people who had extra testing for possible scleroderma just because of that manometry test. But here we are in Chicago 4.0, which is our current diagnostic criteria for motility disorders in general. So by definition, the lower esophageal sphincter should function very well, should relax with swallows, but you need to have one of two things. You need to have more than 70% ineffective swallows of any kind, weak, fragmented, non-conducted, or 50% or more of non-conducted swallows. So the reason that there's less proportion of non-conducted is because, as I said, they're more likely to cause bolus retention and symptoms. If it's a little bit unclear whether they might have IEM, there can be supportive evidence, such as the lack of contractile reserve on multiple rapid swallows, or you can assess bolus transit on impedance or with the barium esophagram. Having said all of this is still not perfect. There are still patients who have true ineffective esophageal motility, really weak peristalsis, lots of failed swallows, who don't have symptoms, who don't have dysphagia, who are just fine. And so one thing that I come back to is the fact that these are findings on manometry. They're not diseases. And just like pathologists say, clinical pathologic correlation required, I think that we need to think about clinical manometric correlation. The other esophageal motility disorder I wanted to review with you is something called EG junction outflow obstruction. Basically, what this means is that during swallows, the lower esophageal sphincter does not relax fully. This came out in about 2015 with Chicago 3.0, and for us in the motility world, it was a total headache. And why? Because everybody thought this was achalasia in evolution, that we caught it early and there's still peristalsis, but with time this will happen. I'm going to just give you the punchline. That's not what it is, okay? Initially, I mean, there's so many studies that were done. People were doing CTs in all these patients, endoscopic ultrasounds. I mean, the amount of investigations these patients had was crazy. Not only that, but it became clear that many of them had no obstructive symptoms. They might have GERD or dyspepsia or some random something else that triggered the manometry. Furthermore, many of these patients, if you left them alone, within 2 years, they felt fine. Even if they had initial symptoms, and many of these manometric abnormalities went away. So what is this? Is this a real thing? What are we going to do about it? So this is just illustrating that the IRP or the LES does not relax properly. With time and a little bit of wisdom and many, many studies, we came to realize that there are certain reasons why people might have this finding on manometry. So sometimes it's a missed structural cause. So sometimes strictures or rings can be subtle. Eosinophilic esophagitis can cause this, and even a mass or external compression. The most common thing we see is actually opioid medication. So opioids can affect not just the lower esophageal sphincter, but also the esophageal body. And in fact, some of these patients on opioids look like they have type 3 achalasia. In an ideal world, we would get them off opioids and retest them. I've only been able to do that in one patient, and their subsequent study was completely normal. But most of our patients are on chronic opioid medication that cannot be stopped. Hiatus hernias, particularly ones of more decent size, can also alter the G junction anatomy and can put pressure on the catheters and give us a false high pressure for during swallows. Sometimes it's an artifact, and you've seen that I've put in tiny, tiny little font at the very bottom, far away, that this could be an actual lower esophageal sphincter dysfunction or achalasia in rare cases. Actually, it's interesting. I think I had one of these patients just last week in clinic, and it was one of those moments like, wow, here's an actual one. But truly, I do not want you to think that this is what this condition is. Just like I said with ineffective esophageal motility, we can use some of the tricks of the esophagus to further understand what's going on at the G junction. So another provocative test that we use is a rapid drink challenge. So basically they get 200 cc's of water and they're supposed to drink it as quickly as possible, then stop. Okay, and this is with them sitting upright. And you can see there are multiple swallows at the top here. What we found, first of all, is that there is not always a peristaltic wave at the end, just like you would have seen with the multiple rapid swallows, just smaller volume, but that's okay. But what this is meant to do is to force the lower esophageal sphincter to relax, because every single swallow tells it, relax, 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 do it over and over again. So if you have somebody where the individual 10 water swallows, the LES doesn't really fully relax, but it relaxes fully and beautifully with a rapid drink challenge, then your LES is fine. So we're not worried about an actual obstruction there. So here's an example of when it doesn't. So this is somebody who genuinely had outflow obstruction. And so the LES did not relax. The IRP here was high, and you're getting this pressurization that's actually reminiscent of achalasia. I will tell you that we often use something called a timed barium esophagram. So this is a barium swallow that is really only for the esophagus, and they sit upright, they drink, again, about 150 to 200 cc's of barium. There's a ruler behind them. And what happens is, if they have outflow obstruction, they'll get a column of barium, and they will measure the height of the column at 0, 1, 2, and 5 minutes later. And that can tell you if there is actual bolus retention and outflow obstruction. And we use this protocol for achalasia as well. Another new technology that that's come in to help us, particularly with patients who may have dysfunction of their AG junction, is flip technology. And again, I actually had to go back through my calendar to see where we started when we started this, and it was 2014, so about 10 years ago. So a functional lumen imaging probe uses something called impedance planimetry, which measures the mechanical properties of the intestinal wall wherever you happen to measure. We measure the G junction in the distal esophagus. And at the G junction, we get two measures. The first one is the diameter. So I always tell our residents that a scope is a very artificial situation. Unless you have a fixed stricture at the G junction that is smaller than the scope, that clearly is blocking you, you can barge your way through anything. You can insufflate, you can push. So what you're getting is not a real assessment of what in real life, when you swallow, how well the G junction opens. And this is what the flip tells us. The second thing it tells us is something called distensibility, which is the cross-section area in relation to distension pressure. Because we have this balloon with a catheter inside, and the balloon is very, very compliant. So this is not for dilation, it's just for measurements. And in simple terms, I think of distensibility as stretchiness, because if you think in achalasia, your lower esophageal sphincter is squeezing so hard. So how well can it stretch and open during swallows? And this technology has helped us in patients who have unclear diagnoses on manometry, patients who have recurrent symptoms after treatment or after surgery. So I'll show you some examples. This is what we initially we used to look at, which is just the G junction. This is the representation of the balloon. This is where the EGJ is. And we would get a diameter, we would get a distensibility, and that would tell us about the function of this area. So here on the left, you have what an achalasia patient would have. So a clear hourglass with a very low distensibility, very, very tight. And on the right, after they've had a treatment, it's completely normal. So we can see immediately the effects. And in fact, this has been used in the OR as well to guide treatment. This is a representation of how we put together the distensibility and diameter. So the ones down here, so a distensibility less than 2 and a diameter less than 12 is clearly abnormal. Then you have the obvious normals over here and the gray zone in the middle. What was observed over time is that as we were inflating this balloon at the G junction to take measurements, things were happening above. And if you see those almost like streaks here, they kind of look like peristalsis does on manometry. But I do want to caution you that these measurements, these streaks are actually measurements of diameter of the esophagus. So if the esophagus contracts, you're getting these higher pressures that go down in a sequence. And what this is secondary peristalsis. So the esophagus is feeling the balloon in the area, so it feels like there's something there, which initiates its own peristalsis to go through. In the parlance of flip technology, this is called a repetitive antegrade contraction, or a RAC, and these are completely normal. If you have abnormal contractility in the esophageal body, they go away. So in achalasia, you don't see this. You can also see retrograde contractions, which are associated with other conditions, but you can see that there's a lot of information that we get from flip, and this is done during endoscopy. Here's a comparison between flip and manometry. These are normal swallows, and this is what you would see. You'd have a normal distensibility at the bottom, normal diameter at the G junction, and these beautiful repetitive antegrade contractions. Here's a type 1 achalasia patient. There's nothing going on in the esophageal body on flip, and the distensibility index is very, very low. So the G junction is very tight and diameter is very low. There are obviously other conditions that you can see on flip, and there's a little bit of a convoluted classification there as well. The hope is that in some patients in the future, they might not even need to have esophageal manometry if you see something on flip. So we're not quite there yet. Even the biggest proponents of this at Northwestern and Chicago are not quite yet there. But I think that this is very intriguing, and certainly saving patients tests, including a manometry, would be a good idea. So here we are with the most up-to-date diagnostic criteria for EG junctional flow obstruction. And I think the top sentence says it all. A manometric diagnosis of EGJOO is always considered clinically inconclusive. So the whole clinical manometric correlation required is so important. You need to look for their medications, their anatomy, hiatus hernias, and so on, which often Dan Sadowski and I do in the lab when we read, but this is important for the referring physician. You need a high IRP, so the LES not relaxing. Now we do the studies both supine and upright, and you have to have clinically relevant obstructive symptoms, so dysphagia or non-cardiac chest pain. You can't just have random non-associated symptoms. Certainly, we can use flip as a supportive measure, and if you see pressurization during the provocative test, during the rapid drink challenge, that can also support things. In theory, you could do even a solid test meal during manometry. We do not do that routinely. We only do that for other motility disorders, but in some labs, they do that. So here we are in 2014, oh my God, 24. And we are in the Chicago 4.0 era of esophageal motility disorders. And I'm not wanting you to go through this entire flow sheet, but again, formulate your thoughts around disorders of EGJ outflow and disorders of peristalsis. And under the category of disorders of EGJ outflow, you've got the 3 types of achalasia and EG junctional flow obstruction. And for disorders of peristalsis, you have absent peristalsis, ineffective esophageal motility, hypercontractile esophagus, and distal esophageal spasm. So this has been quite the journey. For me, clinically, it's been very exciting to bring some of these technologies, new tests, new protocols to Edmonton. But the reality is that we are in a little bit of a privileged position here because we have all of this. Many places in the country don't. And I think that it takes quite a long time for these new diagnostic criteria and disorders for that the information to permeate in the general medical community. And when I started in 2008, 10 out of 17 Canadian medical schools had a GI motility specialist, so everybody was academic. Most places had a single person. And this had a huge effect on training of gastroenterologists. Many GI residency programs did not have a mandatory motility rotation. So despite the fact that GI motility, and I don't mean just esophageal motility, but broadly speaking, is a huge part of general GI practice, huge part. Many of our new gastroenterologists were not seeing it, were not being trained in it. So in 2016, Dan Sadowski and I started a course, a national course for GI residents, adult and peds GI, to basically try to fill this gap. We alternate yearly between the U of A in Edmonton and Queen's University in Kingston, Ontario. We started off with 12 residents. That's our picture of our first course. And you may recognize some current staff. But we've had 113 people come through so far. We've had uniformly glowing reviews, and actually I had to laugh at our last course when we said, okay, what could we do better? And they said there was too much food. Don't buy too much food. That was really what they said. This is fun for us and it's helpful for residents, but does it get us anywhere in other ways? Well, I'm happy to tell you that we've inspired a number of people to pursue a career in motility. We have someone who is now a professor at Laval University, somebody at Columbia University in New York. We have David Yang, who's hopefully going to join us on our division soon. And we have several people in Ontario. So it has been incredibly rewarding to see people be inspired and pursue this career. And not just in academia, there are some who practice motility in the community. But I will tell you that we came up with the curriculum ourselves, what we thought was important to understand about physiology, pathophysiology, management, et cetera, how to read studies and so on. But there's never really been a formal curriculum in motility. Until about 2016, the American Neurogastroenterology and Motility Society and the European Society for Neurogastroenterology and Motility put together a task force to create a curriculum in this field. And I was invited to take part. It's a very long curriculum, so obviously I'm not going to go through all of that, but I wanted to highlight the fact that we divided it among sort of 3 tiers. So if you are a general gastroenterologist, generally in the community practice, who really should just have an approach essentially to these patients, versus someone who would have an interest and more expertise and have a part of their practice be in neurogastroenterology and motility, versus finally somebody who really that's all they do. And it's a very detailed curriculum which has informed the formation of the EPAs for motility in the United States. In Canada, there are actually no EPAs for motility in the GI training. The knowledge is actually spread out through other EPAs. We've used this for the curriculum for our advanced motility fellowship here, and certainly for the motility course as well. So I think that it has been very helpful. This has been endorsed by every motility society in the world, including the Asia Pacific, South American. So this is the standard of care, if we can put it that way. One other thing that Dan and I have done has been a podcast. So the GI 101 podcast, which is available wherever you get your podcast, as they say, is basically a conversation. We talk about various motility disorders. We talk about cases. We talk about physiology and technology. And I just had to check recently as I put this up, and we apparently have over 12,000 subscribers and more than 1 million views. It has been great and fun for us. And then I got to do it all over again in French when we had Achalasia de Mastrodon, who was our first motility fellow, who is now professor at Laval University. So it turns out there's even less motility resources in French, to the point where we had to figure out how to say some of those terms, like distal contractile interval. Do you translate it literally word for word? The short answer is no. We actually said distal contractile interval. We actually use the English words because that's what they do in French practice as well. So here we are in 2024, and 14 out of the 17 medical schools in Canada have a motility specialist. There's 27 of us in academic practice, and at least 5, if not more, in community practice. We now have the Canadian Neurogastroenterology and Motility Network, which is how we get together and try to help each other and build motility in Canada. So it's been quite the ride. It's definitely not the very end. Lots of more exciting things to do. But as I mentioned, I've had the opportunity to work on improving clinical practice and disseminating that information at the same time, which I think has been very, very helpful. As always, we never travel alone. So these are the people that I'd like to thank that were instrumental in inspiring me and supporting me and mentoring me along the way. Special thank you to Dan Sadowski, who's been a friend, a colleague, a collaborator, a role model, and somebody who's equally excited about the esophagus as I am, and also the nurses in our GI motility lab. So with that, I will end and leave you with a manometry patient. By the way, dogs can get achalasia and megaesophagus too. So thank you very much for your attention.
Thank you, Adriana. What outstanding rounds. It's sort of so nice to see an area that we don't hear very commonly about, and somebody who's clearly so passionate about it. I mean, it's sort of really cool to hear your journey and how you've gotten to where you have. So thank you for sharing that. I'm just going to kick it off with really a quick, I guess, real world practical question. There are so few of you, even though you've doubled your numbers across the country. From a practical point of view for primary care physician, internist, non-gastroenterologist, which are the patients that really sort of, in terms of red flags that you should say, okay, we need to send this person to a motility specialist, as opposed to, what we see the most commonly, which is a little bit of GERD and, sort of the complications related to that?
So excellent question. A lot of esophageal motility and motility in general is part of general GI practice. So these general patients who have dysphagia, who have GERD, who may have had, say, a motility test with whatever results, should just go to a general gastroenterologist. In Edmonton with achalasia, you can send them straight to me or Dan because we do have the clinic, although some of my colleagues also look after achalasia, so that would be fine as well. I think if there's ever uncertainty, so if the result on the test doesn't seem to match their symptoms, that's when somebody like me can help, can try to put it all together. I have the flip. I have other tools, which I haven't talked about, that can clarify things. But the short answer is you don't need somebody like me right off the bat. Like, a lot of what I do is actually second opinion for other gastroenterologists in the city or the zone. I'm more than happy to be the first point of access, but as you can imagine, I cannot see all of these patients. Just to give you an idea, we do 1,000 esophageal manometries in our lab per year. We're the busiest lab in Canada, so clearly I cannot see all of those patients. But the short answer is a lot of this is within the practice of a general gastroenterologist.
Dan, oh, by the way, I just need to take this opportunity to congratulate you and Clarence and the team on your initiation of poems last
Thank
month.
you. Very excited about that. Yeah.
Sandra's just asking if there are good patient handouts for these conditions.
Patient handouts. Short answer is no. Funnily enough, a patient asked me recently about something, and I even went up to date because up to date has patient handouts. but they are ridiculously long, ridiculously general, and it's almost overly comprehensive with things that are not relevant to patients. So that is something that we've thought about, particularly at the Canadian Neurogastro and Motility Network level, to do something that's pan-Canada. But so stay tuned for sure. That would be very helpful.
And even working with the SCN at a local level,
Yes.
maybe to develop some of those
For
might
sure.
be.
For sure. Yes. Yeah.
Okay, I'm going to toss it out to you and see if there's any questions in the audience.
Yes, Rob.
Totally practical question that aren't do with totally esoteric, nonsensical question. What do you think happens in the esophagus with water?
Okay, so the question from Rob Pauley was, what? Hey. And what do I think happens in the esophagus with waterboarding? Now, I actually, believe it or not, don't know what waterboarding. I've heard the word. I don't actually know what is involved. So tell me, and then I'll try to kind of figure it out.
So this is where you have somebody recline off their back, torture, advanced interrogation technique,
Okay.
proper torture, and you basically start pouring water into somebody's mouth, and until like they're overwhelmed.
Right.
Presumably happens. Somebody tries hard to swallow.
Yeah.
Swallow.
Yeah.
Like much more so. One of your tests, presumably, except to the extreme.
Right.
And I think
So I think actually in that situation, if you have a normal esophagus, that's not the problem. It's actually going to be your oropharyngeal swallowing, because you're not going to be able to swallow fast enough to get into the esophagus. If you get into the esophagus, things are actually probably going to be not that bad. So you're likely to aspirate. The only thing about the esophagus is that even though in general, with normal esophageal motility, you don't need gravity. Like there's the old joke about swallowing upside down, which you should be able to. If you're flat, or if you're supine, remember that if you're swallowing very quickly, like the rapid drink challenge, you're inhibiting your peristalsis. You're relaxing your lower esophageal sphincter. So in an upright position, if I pour something back, and swallow it quickly, it is going to go down with gravity. So you might have some regurgitation from the esophagus just because you're supine. But my feeling is that the biggest issue is that you are not going to be able to initiate an oropharyngeal swallow fast enough, like so many times, to deal with that volume, and you aspirate and essentially drown. This is kind of what I'm saying. So, any other questions? Okay. So there's no questions from in the room. Is there anything else? Anybody else?
Yeah, there is another question. Is it always clear to distinguish an esophageal cause of chest pain from exertional angina, the bane of many of our existences?
So I'm actually really glad that somebody asked that question, because what happens, what I see a lot, is patients keep coming to emerge with chest pain. They get whatever cardiac test, they say that's not the heart. They get whatever pulmonary test, it's not a PE, it's not an effusion, it's not a whatever. So they're told, you have esophageal spasm. I'm going to tell you right now that the vast majority of those patients do not have esophageal spasm. Okay, so there's some features on history that are very helpful. Esophageal spasm, when it happens, doesn't have to be with meals, but it's short-lived. The esophagus cannot spasm for hours. So if patients come and they say, I get chest pain, and it's there for an hour or two, this is not the esophagus. The other very important question to ask is, if you, in the middle of an attack of chest pain, have you ever taken a drink? Like maybe you're trying to take a pill or whatever. What happens when you do that? Because if your esophagus is spasming and you're putting water in there, number one, you're going to get dysphagia. Number two, you're going to get worse chest pain. Number three, you're probably going to just regurgitate. Most of those patients have no problem. They say, I just keep drinking. I just hope the kid's going to feel better. So clinically, that's a very easy way to tell. Lastly, even in the patients where, there might be something esophageal going on, if we do a manometry test, unless they have symptoms while we're doing it, it's not that helpful. And many of these patients don't have a known trigger. Like if you do, I will say, look, bring that food or do that thing while we do the test and see what happens, okay? I got lucky once. A patient randomly got their symptoms in the middle of a test, and the esophagus was pristine. Their ECG was not, however. But the other problem we run into is that the many things in the esophagus may not actually always be symptomatic. I had a patient referred to me from cardiology who had swallow-induced syncope, which is a very rare condition, where if you have a lot of spasm in the esophagus through some sort of vagal connection, it causes arrhythmias and patients pass out. And when we tested him, he had horrible spasm in the esophagus, like all the time, no dysphagia, no chest pain, and he'd really only ever had syncope twice, even though this was happening in the esophagus all the time. So I guess in summary, first of all, most of the time, patients with non-cardiac chest pain don't have an esophageal source. And if there might kind of sort of possibly be one, this is when they need to see somebody like me to try to tease apart the clinical relevance.
I like that trick about getting them to swallow while they're having the pain. It's great. Okay, on behalf of the department, once again, thank you so much for the grand rounds. Congratulations, so well deserved. And have a great weekend, everybody. Take care. A long weekend. Bye.